Okay, just 1 minute. Okay. So can everyone see the slide?
Yes, sir.
Okay, fine. So today I'll be talking mainly on the evaluation of neck pain. So what are the types of pain we occur that in the neck? And remember, neck pain can be radiating to the two areas. Number one, can go to the shoulders, it can go to the upper back, and sometimes it can go to the back of the head, which sometimes we call cervicogenic headache. So today's topic is not cervicogenic headache, but still a few related topics I'll be discussing today as well. So let's move. Okay, so what's a neck pain? Neck pain is basically discomfort or pain in the neck which is originating from the structures of the neck. For example, muscles, nerves, bones, joints, or intravertebral discs. So these structures from where the pain is generated, usually called pain generator. So these are usual pain generators for the nerve. Now it can range from a mild to very severe. It can be caused by the strain, injury, or some underlying medical conditions. Now, neck pain is globally a very common problem, and two-thirds of the people experience neck pain at any some point of their life. Point prevalence is around 7.6%, whereas the lifetime prevalence is around 48.5%. 12-month prevalence varies between 30% and 50%. Higher incidence is found in women, individuals with anxiety and depression, and neck pain results in incapacity to perform daily activities around 2 to 11% of these cases. So we can understand leg pain is a big issue all over the world, whether it's India or outside. Now, before going into the detailed neck pain evaluation, first an important thing that we usually know before is the what are the red flag signs for the neck pain evaluation. Basically, these are the conditions in the neck when they are found that is usually concerned with serious conditions and requires urgent evaluation and management. Maybe in the form of medical management or in the form of surgical management. These cases cannot wait with a chronic pain. Okay. So first of all, you should begin with history of trauma. You should evaluate what happened, where is the fracture, or there is any significant compression over the nerve or not. So any trauma which is causing neck pain, it is very important to evaluate and then proceed accordingly. A patient with a history of infection, for example, fever, malaise, or nuchal rigidity, these patients are also to be evaluated immediately. Patients with suspected malignancy. So, like unexpected symptoms are there, like sudden weight loss, anorexia, night pain. In those patients also, we should go for the early imaging or that investigation followed by the treatment. Patient with progressive neurodeficit. Okay, so it could be a progressive gait disturbance, could be a progressive motor weakness, or sensory disturbance or sensory deficit, and patient with bladder bowel incontinence. So, whether it is sensory, motor, or autonomic, all these patients should be immediately evaluated and treated accordingly. Patient with the acute neurologic or hemodynamic instability, like progressive cognitive deficit, hemodynamic instability, patient with associated symptoms like chest pain, tachycardia, breathlessness, patient with Horner syndrome. So these are the conditions that are the red flags, and here we cannot do it. But remember, neck pain is a very common entity. Now, a lot of patients comes to the OPD with a chronic neck pain. They do not have these red flag signs. So for them, our treatment protocol slightly different. So we'll be discussing how to evaluate patients with chronic neck pain. So first and foremost thing is to evaluate whether the red flag signs are present or not. If the red flag signs are present, go for immediate management according to the symptoms and investigation. Now, before going to the neck pain proper, let us discuss about the anatomy of the neck. And we'll be understanding which structure can cause neck pain and which structure is anterior, which structure is posterior, what type of pain can be happening from one structure. So, neck have 7 bones. These are basically the cervical vertebrae, which is counted from cervical vertebra 1 or C1 to CH. Just 1 second. Okay. So, in a cervical vertebra, we have the following things. Typical cervical vertebra, we have a body which remains in the anterior side. We have a pedicle which is connecting to the body to the pars intra-articularis. Then we have the articular pillar. Remember, there is a difference between the cervical and lumbar vertebra. In cervical vertebra, usually the size of the body is smaller, whereas the outermost portion that we can see are the articular pillars. And these articular pillars is having facets, one at the top and other at the bottom. Upper one is known as the superior articular facet, and the lower one is known as the inferior articular facet. Now, from this area, we have a transverse process. But in the cervical vertebra, transverse process having a specific character, that is having a foramen in the side of the for the transverse process. This is known as the foramen transversarium. This foramen is for, can anyone tell for which structure this foramen is made for?
Vertebral artery.
Vertebral artery.
Yes, very good.
Yes.
Vertebral artery. And this artery is not present within the transverse process of which vertebra?
7.
Seventh cervical vertebra, because it enters at the sixth cervical vertebra and then it continues. And in these vertebra, there are this actually transverse processes. That is a specific characteristic of the cervical transverse processes. But there are two tubercles. One is the anterior tubercle and one is posterior tubercle. So this one is the anterior tubercle and this one is the posterior tubercle. And if we look at, just 1 second, let me open the anatomy application, then it will be much easier for you to understand. So I'm opening the, let me share it with you. Okay. So I think you can see this vertebra and I am going to the cervical area. So in cervical area, we have some atypical characters. As I told, the vertebral body is smaller, just compared with the lumbar one. So when we are going to the lumbar area, see, the most widened portion is the vertebral body. But in the cervical area, you check, the body is smaller, rather these articular pillars are the most wide portion. Along with that, I have told that these transverse processes having the openings, that is the foramen transverse area, and there are articular pillars joining with one another. Now there is another atypicality of the cervical vertebral body as well. You look at the sides of the vertebral body, this area and this area. They are not like lumbar vertebrae. That is, they are not straight. See, these are the thoracic vertebrae. Here the sides are straight. But in cervical area, there is a lipping. So we can see this lipping. And this side lippings or this elevated areas are known as the uncinate process of the cervical vertebra. they give some stability for this area. Because remember, in thoracic area and in lumbar area, the structures are much wider, but our neck is much short and smaller, so they need some additional reinforcement, and this provides a little more stability in the cervical spine. So this is all about the typical cervical spines. There is another atypicality as well in this cervical spinous process. Unlike the lumbar spinous processes, cervical spinous processes have bifurcate appearance. You see, left and right. So this starts from the C2 and then continues till the C4-5 area. Okay. Then it becomes C7, which is known as the vertebra prominence. See, this is the C7. This is known as the most prominent vertebra or the vertebra prominence. Now, if we go at the level of the C1 and C2, so I am isolating this structure and we can see this structure is slightly different. How it is different? So it do not have a body. It neither have a spinous process. It has a small tubercle. Anteriorly, there is a facet attached with the odontoid process of the second cervical vertebra. And above this facet is for the occipital bone. And if we look at the axis, which is known as the C2, it is having a process in the anterior side which attaches with the process of the C1, and this is forming a junction. And the first facet joint, what we see from the lateral side, is basically the C2, C3 facet joint. Okay. So I have not talked about the facet joints. So as we are beginners, so we have to talk about the facet joints as well. Facet joints are formed by these junctions. That means the inferior articular facet attaches with the superior articular facet, and this forms the joint in the posterior side, and they are known as facet joints. Then we have the laminas. This portion of the laminas, the joining to form the spinous process, and other side they are attached to the articular pillars. Now, within this, definitely the medulla oblongata comes and becomes the spinal cord. So let's be back to the presentation. I think basic anatomy you have understood. Next, we'll be moving towards the next portions. Now, here in between, we are having the spinal cord, and in between two vertebral bodies, we have this disc. Now, disc have two structures. The outer side is known as the annulus fibrosus, and the inner side is known as nucleus pulposus. So, what is the difference between the annulus fibrosus and nucleus pulposus? The main difference is in the water content. Nucleus pulposus is a jelly-like material which remains in the inner side of the vertebral disc, and these annulus fibrosus, they are fibrous structures. They are formed by the collagen, which remains in crisscross fashion to make it more stable, and it is having a big responsibility of absorbing the shock. For example, if there is a sudden weight increase or decrease, it actually dampens it back to the shock absorber. Now, there are the from the spinal cord, anterior and posterior roots combine and form the spinal nerves. They come out through the foramen. Remember, here there is a difference between the lumbar vertebra and the cervical vertebra. In the lumbar vertebra, these foramens are directed exactly towards lateral side. Whereas in the cervical area, they are directed a little bit around 60 to 45 degree anterior and around 30-degree inferior side. So the direction of the nerves when it is coming, it is not purely lateral, then it is a little bit anterolateral and inferior. Now, these nerve roots are forming these spinal nerves. They are going to supply mainly the neck, upper limb, upper part of the shoulder, upper part of the chest. So let's continue the muscles. So what are the muscles we are having in the neck? We have four big muscles. In fact, if you name it, it will be two because left side one, right side one. They are the flat sheet-like muscles. Posteriorly, it is the trapezius. You see, the trapezius is a big flat muscle which is attached to the nuchal line. Then it is also attached to the. Let us go to the anatomy again, but it will be easier for you to understand because 3D anatomy is very, very important. So here, if you look at this area, so we can see this is the trapezius. It is attached to the superior nuchal line. Medially, it is attached to the spinous processes and it continues here. Some fibers attached to the outer third of the clavicle, then over the acromioclavicular joint, then whole of the acromion and the lower fibers, they come from the lower part of the thoracic spine, spinous process, and they continue up and they attaches more towards acromion process. They are the sheet-like muscles in the back. Remember, it is a very important muscle, and especially it can cause one condition that is known as the myofascial pain syndrome. Usually, due to COVID, you have seen a lot of people are working in the computers. So what happened to these patients? While they are working on the computer, there is a continuous stretching and the pull of these muscles, leading to development of myofascial trigger points within these muscles. Now coming to the anterior side, we have a sheet-like muscle platysma. That is not that important muscle. Then we have the big muscle. It is the sternocleidomastoid. Okay. So just one second. We have the sternocleidomastoid. So here you can see it has a sternal head and a clavicular head. And these continuing above and attaches to the mastoid process, close to the mastoid process. Then we have the upper sheath muscles. They are very, very, very small muscles, mainly the sternohyoid, sternothyroid, and along with we have a upper belly of the omohyoid in the anterior portion of the neck. After, if we hide the trapezius, we are having the deeper muscles of the neck. Then we have one important muscle. This is known as splenius capitis, which is splint-like. Then just under it, we have another muscle that is known as the semispinalis capitis. Remember, this semispinalis capitis is very important for the management of pain because under this semispinalis capitis remains a nerve that is the greater occipital nerve. Then we reach to the occipital triangle, and here we have four important muscles, among which one important, very important muscle is their obliquus capitis inferior. Then we have the rectus capitis posterior major, rectus capitis posterior minor, and obliquus capitis superior. And under which we are having the occipital triangle and we are having the suboccipital nerve. So I think this much in anatomy is quite good. So I will not be digging more deep into the anatomy because we'll learn the anatomy along with time with the patients and with the other things. So the muscles, then we have the important nerves and vessels. But let us first try to find out what are the causes of the neck pain. First of all, causes may be originating from the cervical spine. For example, pain might arising from very small joints. These are the facet joints in the cervical spine. So we have these very small joints in the cervical spine known as the facet joints. Pain might be coming originating from this facet joint. Remember, we're talking about chronic pains here, facet joint arthropathy. Then cervical discs might be degenerated, and this condition is known as the internal disc disruption. Then pain can be caused by the intravertebral disc, prolapse, which is causing inflammation at the nerve root. So that will cause a neuropathic pain in the shoulder and the hands. And depending on which root is involved, pain will be going to these areas. Cervical radiculopathy. Remember, cervical radicular pain and cervical radiculopathy are similar terms. And there are some difference. We'll be discussing soon about those. This cervical root compression can lead to the cervical radiculopathy. Now, vertebral fracture might occur due to trauma and intraspinous ligament sprain. So, in between these small spinous processes, we are having the intraspinous ligaments. And intraspinous ligament sprains can also be a cause of pain originating from the cervical spine. Next goes to the muscles. As I told, there is an entity which is known as the myofascial pain, or sometimes it is characterized by presence of trigger points. Trigger points are the tender and sensitive points from where the pain originate. Remember, muscle as a whole is not having any pain generator. But when the muscle is sensitized, there are formation of trigger points within these muscles, and that can be pain generator, and they are the myofascial pains. So myofascial trigger point is quite common in trapezius, sternocleidomastoid, occipitalis, and other deep muscles of the neck as well. Sometimes it is very difficult to differentiate without ultrasound. They can be painful. It can occur from the joint disorders, like a degenerative joint disorder. First joint arthropathy is also a type of degenerative joint disorder. Then it could be caused by the inflammatory process like rheumatoid arthritis, and more commonly by ankylosing spondylitis, which can cause neck pain, low back pain, sacroiliac joint pain. The inflammatory process might involve all parts of the spine. Next is the causes of the neck pain, which is referred. So sometimes there could be referred from the shoulder, pain originating from the heart or lungs, sometimes may appear to originate from the neck as well. Diaphragmatic irritation and sometimes the abdominal pathology like hiatus hernia, they can also cause neck pain. So we have to differentiate this type of pains. Then coming to the other causes of neck pain that might occur like post-herpetic neuralgia. Then involving this specific nerve roots can cause post-herpetic neuralgia. Diabetic poly or mononeuropathy can cause pain here. Occipital neuralgia, another very common cause of the cervicogenic headache as well as neck pain. Brachial plexus neuropathy can also cause pain in the neck and the hand. And complex regional pain syndrome, which is basically a sympathetic hyperactivity syndrome that can occur in the upper limb as well as in the neck and can cause pain in the neck. As a whole, we can think these are the common causes of the neck pain. So, keeping in mind these red flag causes as well as these causes which can cause chronic pain, we'll start evaluating the pain now. So, what are the common causes of the neck pain? Among the common causes, remember, here the most common cause is from the muscle sprain, tension, and sometimes the myofascial pain originating from this, especially the chronic pains are most because of the myofascial pain. It can be caused by degenerative disc disease, which is very common in young age, and that can cause a dull feeling pain in the neck. Remember, disc as a whole can cause two types of pain. One type of pain is a radicular pain, okay, or radiculopathy, which is actually a radiating pain along the dermatome. This pain is primarily neuropathic. The neuropathic means, I think last day it is discussed. So it has some special characters. Among those special characters are the tingling, numbness, burning, change of pain with the temperature, okay, and crawl-like feeling. So this type of sensations are usually present. So radiculopathy usually or radicular pain usually occurs from ectopic discharge of the nerves, and that can cause more of a radicular pain. That's the primary neuropathic type of pain. When degenerative disc disease can cause a dull and which is poorly localizing. So pure dynamical distribution will not be there. It is more like a visceral sort of pain. It's a dull ache. So it's a difference between these two types of pain. Next, pain can be originating from these joints. That means the cervical facet joints. Okay. So these small joints are actually the cervical facet joints. And when the joints are inflamed because of an inflammatory process, or it could be because of degenerative process. So that can cause a pain. So how it will appear? A cervical facet pain. It should be well localized because it is a joint is a small space. And the patient will say, having this joint or this pain. And this sort of pain is usually aggravated by movement of the neck. For example, while we are moving the neck towards the back side, see, these are the structures at the back. So it is stressed when the neck is actually, we put the neck at the posterior side. So when the neck is at the back, then only these pains can increase more. So that is one of the characters of the cervical facet pain. And as it's a joint pain, usually at rest, the pain will not occur. As the patient start movements, the pain will occur. That is also a characteristic of joint pain. Regarding the myofascial pain syndrome, it's a very chronic type of pain where the trigger point or a sensitive point sometimes will feels like a nodule, or sometimes the whole muscle is involved. It might feel like a low, and this when we placed, that can cause sudden contraction of that muscle, and sometimes it is called the jump sign. Okay, so that is what is the myofascial pain syndrome, and definitely the psychological factors also can contribute to cervical cervical pain. So, keeping in this diagnosis in mind, let us discuss a little bit about the specific type of pain. So, before going to the specific type of pain, if you have any questions regarding what I have just told, you can ask me. Please switch on your microphone and you can ask. See, unless and until you are clearing your doubts, if I talk 1 hour, 2 hour, doesn't have a value. So please,
Sir, most of the hello, sir. I'm Dr.
yes,
Srinivas.
yes,
Most
welcome.
of the patients come to me with
Yes,
not in the midline pain, sir. They come to the in the lateral side. The middle means almost around 2 to 3 centimeters lateral, either to the left side or right side. There won't be any radiculopathy. So
yes,
these are the patients coming to me, and some
yes,
patients what happen just above the this one like in the cervical, just below the neck, that means just below this cranium, the pain will be
yes.
there more, and which is leading to the headache, sir. So these two type of patients I am getting more patients.
Okay. So it is quite common when you are getting an aged patient. What is the most common cause of pain in the aged patient? From the myofascial and muscle origin pains, the most common type of pain is the facet pain. So what we'll be discussing now. Basically, these facet pains are well localized pain. They are not central pain, they are paracentral pain, which is occurring 2 to 3 centimeters from the midline. And in this patient, if you put pressure over this facet joints, it will be painful. So most probably, you are dealing with either a myofascial pain or a facet pain. These both type of pains are quite common. And now these facet joints are supplied by the nerve, especially in the upper part, in the C2C3 facet joint. It is supplied by a nerve which is known as the occipital nerve. The third occipital nerve supplies upper part of the neck. Okay, so third occipital nerve starts from midline, and then it goes over the C2C3 facet joint, then it moves up. In the way it supplies the C2C3 facet joint as well. So when the pain is involving the C2C3 facet joint, it can cause pain along the third occipital nerve. And remember, that is what is known as the cervicogenic headache. Similarly, pain originating from the greater occipital or lesser occipital nerve, they can also be referred to the back of the head. So occipital neuralgia could be one cause. One cause may be irritation of the occipital nerve. It is not neuralgia. Remember, it's not a permanent change in the nerve. But here, what is happening? It is the irritating occipital nerve and causing a cervicogenic headache. and sometimes it could be a facet pain that could be another possibility. And definitely, myofascial pain can also be referred to the upper areas. So these are usual diagnoses under such conditions. Okay,
Thank you, sir. Thank you,
so
sir.
let's move towards what you have asked. It is the cervical facet pain. So over 50% of the neck pain caused which comes to the pain clinic are mostly facet related. And key symptoms is the unilateral neck pain without radiation to the arms. And pain, usually there is pain increases during neck rotation, because see, when it is rotating to the left and right, then the pain will be more, because then there will be more pressure over these joints. Okay, so neck rotation will increase the pain, as well as the extension of the neck towards the posterior side. That is the retroflexion. No, we can call it as an extension as well. So what is happening as the structures are at the posterior side? When the patient will try to put the head at the back, the pain will increase. So these are the signs of the typical facet joint pain. And on examination, if you put pressure over these facet joints, the patient will call that this pain joint is painful. And remember, there is another tip or trick by which we can see whether the facet joint involved is a lower facet joint or upper facet joint, is that ask the patient to bend forward and then rotate the head. So what happens when the patient is bending forward and rotating the head? Mainly the stress goes over the upper facet joints. Okay? And when you ask the patient to bend backwards and rotate the neck, and if the pain is increasing, that goes towards more chance of involvement of the lower facet joints, because when we extend and rotate the head, usually more stress is over the lower facet joints. So by that way, we can find out whether it's the upper facet joint involvement or lower facet joint involvement as well. These are very important tips, and when in practice, I think it will help you a lot.
Excuse me, sir.
Yes,
Sir, that facet is loaded when we extend it only. Then for
yes,
up, you're telling for upper facet, we need to flux and then rotate.
yes. Why? Because see, extension puts all over the facet joints. But see, two forces that can actually occur in two axes. One force is definitely forward bending or backward bending. Another type of force is the rotational force. Both type of force increases pressure over the facet joint. Now this, when we are forward bending, then definitely the lower part and upper part. So this, because of the flexion, the area is released. But when we are putting a rotational force, that is putting pressure over more over the upper facet joint. It's because of the rotational force we are getting pressure over this upper facet joints. Okay.
Okay, sir. Sir, it's still little bit confusing. Sir,
Okay.
when
With the model I am trying to explain. Okay. So when see, these are the facet joints. Okay. We can put stress over the facet joint either by extension or by rotation. Both actually can put stress over the facet joint. Now, as a whole, when we are talking, this extension, putting it over to this side, that will actually increase the pressure over all facet joints. But when it's coupled with rotation, pressure will be more. So that part is clear. But rotation, how much pressure is put on by the rotational force will depend on which area is getting more rotational force. Okay, and it has been found that rotational force increases in the joints when we are flexed neck and rotating. Then upper facet joints are mostly involved in such rotation. Okay, so there is more force over this joint when we are flexed and rotated. When we are extended, then it will increase the pressure. That's okay. But specifically, when we are flexing and rotating, this rotational force is more. That will cause pain in the upper facet joint. Yeah.
okay, sir. Thanks.
So, coming to the symptoms. So first of all, it should be an axial neck pain, either or not, or rarely radiating past the shoulders. Remember, facet joint pain is having a referral pattern. It can go up to the shoulder, but it do not go to the hands. When pain with the pressure on the dorsal side of the spinal column at the level of the facet joints. Just now, one of our colleagues had talked. But from the center to 2 to 3 centimeter away, when we are putting pressure, there will be tenderness. Okay, that is over the facet. And pain with the limitation of the extension or rotation, because I have already told these are the maneuvers actually puts more pressure over the facet. So when the pain is more, the patient will not be able to extend. There will be limitation because of the pain, or the rotational also will be limited because of the pain. And definitely, as it is not a compressive neuropathy, there will be no neurological symptoms. Because remember, these small facet joints are supplied by very small nerves. These are known as the median branch of the dorsal rami. So, if we look just 1 second, I am going to the anatomy slide again because I will show this nerve to you because this is very important. Otherwise, it will be difficult for you to understand. Okay, so let me share it. Okay, so look at this area. So I'm just hiding the cutaneous nerves and the superficial things. Okay, muscles. Hide, hide. Okay, so I am looking close. You see some nerves. These are the main nerve root. Okay, this is the C5 spinal nerve. Branch from the C5 is coming back. Okay, so this is the dorsal rami, and this door from this dorsal rami, two branches goes. Okay? Basically, there are three branches, but we should consider for this facet joint mainly the medial branches. There are medial, lateral, and intermediate branches. Medial branch usually goes upper part to the supply the upper facet, lower part to the supply the lower facet joint. So branches from the dorsal rami, mainly the medial branch from this dorsal rami. So there will be one over another subsequent dorsal ramis. And from this dorsal ramis, very small nerves they take origin and they supply to the facet joints. And while going, it remains just at this groove. Okay. So if we see this undulation, see, look at these undulations. So it will be like a hill, then valley, then hill, then valley. So among these valley portions, usually remains this median branches, and that goes to supply this facet joint. So for the treatment, for the long-term benefit for this facet joint arthropathy, the facet joint pain, we can block permanently or in a long term these small nerves, and that is known as the medial branch block. Okay, so we'll be learning one over the other. So gradually we'll be learning everything. So let's move. So this slide we have understood. So there will not be any neurological symptoms here for this patients. Now coming to the referral pattern. Though I have told that will not be any um, there will not be any dermatomal pattern or distribution of the pain, but there will be a referral pattern. According to this referral chart, we can see the superior facet joints like C2, C3 will be having pain in this area, mostly at the back of the head and upper portion of the neck. Whereas the C4, 5 will be having pain distribution in this area. C3, C4, C5, C6, and C6, C7. So pain from the facet joints can refer to these areas, and sometimes this goes unnoticed. Okay, sometimes you can think it's from the muscles. It's not easy to differentiate definitely whether it is coming from the muscle or it is coming from the joint, but definitely we can go for the diagnostic block and we can find out which structure is painful and what is causing the pain. Okay, so this is the typical referral pattern for the facet joint pains. Now, regarding this facet joint, let us discuss a little bit about the similar topic, that is the whiplash associated disorders. So what is whiplash associated disorders? So in past, it has been associated with whiplash. That's why the name is. It's a type of the acceleration deceleration injury. So basically, nowadays it occurs when the body is in motion and suddenly it comes to an halt. So common thing is a car accident. Okay? So there what is happening? Our body is fixed at the seat, my head starts going suddenly to the front. So basically, it's an acceleration deceleration type of injury. Or sometimes when I am supported, head suddenly stacks the back. So ultimately, this acceleration deceleration between these vertebral bodies, they can cause a facet pain as well. Okay, and that is also known as the whiplash associated disorder. And remember, it is not that is only cause facet pain, but it can cause fracture, it can cause muscular injury, it can cause nervous injury, everything it can cause. But one of the most common cause of the whiplash associated disorders is actually facet joint pain. Now coming to the classification of the whiplash associated disorders. It is usually classified like this: grade 0, there is no neck pain and no physical signs. Grade 1, no pain with no serious pathology and minimum impact on daily activities. Grade 2, neck pain with no serious pathology but significant impact on daily activities. Grade 3, neck pain with the neurological symptoms associated with the decreased reflex, muscle weakness, sensory loss. And grade 4, neck pain with very, very serious pathology like fracture, myelopathy, neoplasms. These are actually all classification. Sometimes it is actually a neck pain classification that is applied to the whiplash associated disorders as well. Now coming to the second type of pain, that is known as cervical radicular pain. Remember, today we are not going too much about the discussion of the treatment and the other parts, but we have to first know what are the diseases we are dealing with. Then definitely we can go and we can learn other parts. Now coming to the cervical radicular pain. I think this awareness of this pain is very, very high, and mostly we get a lot of diagnosis of the cervical radicular pain. But remember, though we call it the cervical radicular pain, but the pain mostly in the upper limb. It is not at the neck because here mostly cause is at the neck, but effect is in the upper limb. So what is the cervical radicular pain? Cervical radicular pain is defined as a pain which is perceived as arising from the arm, which is caused by the irritation of the cervical spine, the nerve, or the nerve root. Okay. So basically, here there is either a pressure compression over the nerves, or sometimes there could be possible that there is a ectopic discharge from the nerves because of the injury or inflammation. So these are known as the cervical radicular pain. But there is a term difference when we say cervical radicular pain and the cervical radiculopathy. So remember, in a number of cases, in a number of books even, this term sometimes written as an overlapping. Okay, sometimes they call it a cervical radicular pain, sometimes call it as a radiculopathy. Though there is not a big difference among those terms, but definitely there is a difference among these two terms. So what are those differences? So as a definition, cervical radicular pain is the symptoms caused by the ectopic impulse generation in the nerves. Whereas cervical radiculopathy, which is an objective loss of sensory or motor function, sometimes there could be a loss of reflex as well. Primary cause is the irritation or inflammation of the nerve root, and cervical radiculopathy, the main cause is the compression or damage of the nerve roots. Symptoms: cervical radicular pain is pain radiating along the pathway of the nerve, whereas in cervical radiculopathy, it includes radicular pain plus minus, because sometimes the pain might go away as well, neurological deficit. So it could be a motor deficit, it could be a loss of reflex, or it could be a sensory deficit as well. Neurological signs: in cervical radicular pain, the nerve function is intact, whereas in cervical radiculopathy, there could be a sensory loss, there could be a muscle weakness, or decreased reflexes. Terminology, though it often synonymously used, but remember, radiculopathy is usually a more concerning feature than the radicular pain. So that is how the difference between the terminology. But remember, even today, sometimes the diagnosis, whoever done the diagnosis also mixed between these two terminologies. No pure difference, we should know always. So what is cervical radicular pain and cervical pain? Now this chart, what we are seeing, that you have to remember for your life. Okay. So when the pain is involving the C5 root, pain is moved towards the shoulder. Okay? It can go up to the elbow or slightly below the elbow, but it do not reaches the thumb. Okay? So remember, C5 radiculopathy typically presents as a shoulder pain. Okay? So patient with a shoulder pain with a little bit of neuropathic component sometimes present, along with there is no restriction in active or passive movement of the shoulder, you should think of it could be possible that C5 cervical radiculopathy could be there. So in all causes of shoulder pain, whether it's the SASD bursitis, whether it is the bicipital tenosynovitis, whether it's the acromioculavicular joint arthritis, the differential diagnosis is always C5 radiculopathy. Okay? So remember, C5 radiculopathy mostly causes a pain in the shoulder, sometimes radiating towards the hand. Whereas C6 goes typically to this thumb. Okay, so by which we can remember C7 usually goes to these two fingers and C8 the posterior portion. So in that way, we should remember if the patient is saying that I am having more problem in this thumb, so there could be a C6 radicular pain or C6 radiculopathy. Okay, for the C7, it can go to this finger. So, and this is the typical symptoms the patient usually says. I am having a little bit numbness in these two fingers. Okay, I am having numbness in the little finger. So, by that way, the patient actually tells, and you can try to find out the cause from this diagnosis of the patient. Similarly, from the back, you can see these are the distribution of the stomatomes. So if the pain is there, we can actually think of it could be possible radicular pain. So we can summarize in a short. C4 pain mostly confined to the neck and the suprascapular region. It do not come to the shoulders even. Okay, C5 leads to the neck and upper portion of the arm at the shoulder. C6 radiates from the neck, shoulder, forearm, hand, covering the posterolateral upper arm. Okay. Then C7, similar to C6, but pain extends more dorsally from the neck to the shoulder to the forearm and hand. We can differentiate by this, which area it is going. So coming to the diagnostic approach. No, there is single gold standard diagnosis. That means this is present or this investigation I have done, so this could be C5 radicular pain. Remember, electrophysiology is usually normal when there is only nerve root irritation. So we will not be getting the electrophysiological deficit there. Okay. Only in case of radiculopathy and in later stage, you can go for the electrophysiological changes. So initial diagnosis is mainly based on the history, clinical examination, and definitely investigations. Neurologic examination includes the test of sensation, assessment of the strength of the different muscle, as well as the tendon reflex evaluation. And there are few important tests like Sparlang's test. They are known as the special tests. Okay. Then we have the shoulder abduction test, axial traction test. These tests actually help to make the diagnosis. Now coming to the steps of evaluation. So as I told at the beginning, when the patient comes with the shoulder pain, so what will be the first job is rule out the red flags. Okay. So because the red flags, if you miss, that's a criminal offense actually. So you should not miss a red flag. So again, I am repeating. So I think I will ask everyone. So everyone, 5 of you, be ready, and you one by one tell. Okay, put your hand. And we will be talking. We will be telling about 5, 6 red flags. So what are the red flags? One by one.
Trauma, sir.
Okay, first of all, trauma. Next,
Malignancy.
Infection.
possible
Infection.
malignancy.
Malignancy.
Perfect.
Infection.
Infection or inflammation.
Infection. Okay. First of all, infection, and along with the systemic features of infection. So what could be the systemic features of infection? It could be fever,
Fever.
malaise,
Fever,
it could be
malaise,
chronic bruising,
rigidity,
okay, signs of meningism. So they are also signs of infection. Next,
Hemodynamic
neurological
instability.
changes,
neurological,
Myelopathy.
progressive neurological deficit. Okay. So if there is progressive weakness of the muscles. So there could be a sensor deficit, could be a motor deficit, there could be a autonomic deficit. In
Bowel
autonomic
bladder.
deficit, there could be bowel bladder involvement, and in the sensory and motor deficit, there could be numbness in the area, could be loss of sensation, or sometimes there could be loss of power. And along with there would be loss of reflex as well. Okay, so these are the actually red flag signs. So if we got this red flags, we have to investigate immediately and go for the specific management. Now we have ruled out the red flags. So there is no red flag signs present. Now we should go for the history taking. First, we'll go for the general history taking. Then we should go for the specific history taking. But remember, almost of the cases in a busy OPD, sometimes the general history taking is lacked a little. Still, you train your staff to take the basic histories of the patient, if whether the major illness is present or not, if there is any family history of the any rheumatologic disorder or a spondyloarthropathy is present or not. This type of thing, genetic history, this sort of things we have to take in the general part of the history taking. Then we'll go for specific history taking. Okay, and then we'll go for the examination. An examination has the following component. First of all, general examination. Then we will go for the inspection of the specific site, then palpation, range of movement analysis, the neurological examination, then special tests. And next we have to go for the investigations. So common investigations are the imaging studies, blood investigations. Okay, so we have to go step by step. And at the end, we'll go for the diagnostic interventions. Now, do you have any concept of the diagnostic intervention? Can anyone tell what a diagnostic intervention is?
No, no.
It is when you make a small
Check and
injection of
say, but what is the basic concept behind a diagnostic intervention?
To diagnose the
Which
pain
nerve root is
generator,
involved?
specific pain generator.
Yes. Fact is, why we do require a diagnostic intervention? That is the first question. Because it has been found this spine is a very complex structure. Remember? So sometimes what is seen in the best of our investigations. Say today we call the MRI is mostly the best investigation. Apart from few cases like where we prefer the bone scan over the MRI, like a facet pain, bone scan could be a little bit more helpful over the MRI because MRI do not show any functional thing. It is only structural thing we can see with the MRI. So there could be possibility that even with the best of the imaging, we are not able to find out the cause of the pain. Okay? That might occur in a good number of cases. And also, in the same time, it also happens to a big number of patients that there we are finding pathology in the spine, but that is not causing pain. Okay? Sometimes you do MRI in an aged patient. So accidentally, suppose that is a back pain, you have done a whole spine. So you will be found 2-3 degenerated discs in the cervical spine. And that is not causing pain. Sometimes there could be a herniated disc also. That is not causing pain. Because to cause a pain, it requires not only a mechanical involvement, but also a mechanical involvement in such an extent, along with some functional component like inflammatory components at the root that can incite the event. In a number of cases, we found pathologies which are not causing any type of pain. Now, when pain is patient is saying the pain, and with the investigations, we are either not getting any pain source or we are getting any pain source, but we are not sure whether. Please do not play with the screen, okay? Mohammed Tar, you are just drawing something on the screen. Please do not do that. There is no need of that. I don't know how to remove this. Okay, I think I have to clear all the drawings. Annotate. Clean drawings. I know it is gone. Please do not draw over it, okay? So the thing is, here, sometimes what happens that you are actually not finding the correct pain source. So what is our way? So there is a simple concept that if any structure is suspecting there could be a pain, I put local anesthetic on it and I check whether pain is gone or not. So it's a form of a functional test actually. So suppose I am feeling this facet joint, any cervical facet joint is painful. So what I can do, I can go with the needle to the nerve supply of the specific facet joint. Remember, in lumbar area, you can go for the intra-articular injection as well, but in cervical area, intra-articular facet joint injection is not very popular because one, it's technically difficult. Number two, there could be possible the capsule of this facet joint might not be intact. So in that case, some drugs spill over to the adjacent structures. Our diagnostic efficacy is also lost. That is quite common in the cervical area. That's why the nerve supply of the facet joint, we put local anesthetic over it. Ask the patient whether the pain is present or not. If the pain is not present after giving local anesthetic to the specific joint or the nerve supply of that specific joint, we can tell that the pain is actually originating from the joint. Similarly, if there is a myofascial trigger point in one of the muscles. So what is a myofascial trigger point? Remember, as I told, in normal conditions, the muscle do not have any pain generator. Usually, while doing any procedure, we usually give the local anesthetic in the skin and subcutaneous tissue, and then we put the needle. Usually, we do not go along the whole muscle and give local anesthetic because the normal muscle do not have the pain generators in it. But when muscle is pathologic, there are 2-3 hypotheses by which actually a nodule within the muscle is formed. And this nodule becomes pain target, pain generator. From there, the pain takes origin. So if we put local anesthetic within that trigger point, and if we can find out the pain relief is there, so we can say the origin is from that trigger point. In a specific joint, we can say this joint, say C2, C3 facet joint or C4, C4 facet joint, they are painful. Similarly, if we are suspecting a neuropathy and we are injecting a small amount of now local anesthetic to this nerve, for example, occipital nerve. We are putting a small amount of just 1 second of local anesthetic over the nerve, and we found pain relief there. So it could be a diagnostic intervention. So the role of diagnostic intervention is huge in pain management because it has actually changed the scenario of the pain management. So always we should think of these structures by which we will be evaluating the patient. Now, coming to the pain history. So in pain history, what we ask the patient, first of all, how much is the intensity of the pain, or it is the quantity of the pain. Okay? So it is mild, moderate, severe. That's a very simple sort of classification we ask. Or sometimes we give a VAST scale, that's the visual analog score scale, and visual analog scale, and ask the patient, please show over the scale to which level your pain is. Okay, this is very important because if you are going for a diagnostic intervention, your initial VAS should be more than 4. Otherwise, it is very difficult to understand whether the pain relief is there or not. Though this VAS or numeric analog scale or visual analog scale, they are not very precise scale because these all scales are pain scales are very subjective. It varies patient to patient. When compared with the initial pain and the after pain of a same patient, then definitely visual analog score works here because all the other parameters remaining the same. Okay, the psychological condition and everything remaining the same. When I have done the procedure, I can check whether what was the initial VAS and what is my final VAS. Intensity of pain we have to ask, and character of pain. So what are the characters of pain? For simple words, we say it's a 3 types of pain. One is the neuropathic pain, one is the nociceptive pain, I should say nociceptive first, nociceptive pain, neuropathic pain, and there is a third kind of pain that is known as nociplastic pain. Okay, so let us describe a little between these two to three pains. I think last day it was discussed a little. Can anyone remember what is between the nociceptive pain, a neuropathic pain, and a nociplastic pain?
Nociceptive pain is due to damage or actual tissue damage or that is
Yes.
caused.
So, in simple words, just try to remember, if you got an injury, the kind of pain you receive is basically nociceptive pain. Now, what is the neuropathic pain?
It occurs due to any lesion of the nervous system.
Nervous.
Yes. Either it could be possible, there could be a nervous system injury, as I told a little bit earlier, directly pressure over the nervous cervical radicular pain. So it is a primary neuropathic pain. It has 7 characters what it gets when it is having this neuropathic sort of pain, among which tingling, burning, electric shock like numbness. When change with temperature, the pain will increase and decrease with the change of temperature, and crawling sensation and fine touch can increase the pain. So these are the all 7 characters of a neuropathic pain. So when they are present, it should be called a neuropathic pain. Then what is nociplastic pain? It's a newer concept. Actually, nociplastic concept was not there before 2016. So it is the IASP we came out with a type of pain definition. That is a nociplastic pain. What is it? See, there is a disease known as the complex regional pain syndrome, or there is a disease called the fibromyalgia, where there is a unexplained, okay, unexplained neuropathic pain, okay, and it could be regional like CRPs, or it could be generalized like fibromyalgia, but we are not getting any cause. Okay, that is actually the nociplastic pain. So all those vague pains that initially are considered sometimes psychological, sometimes it was called a functional pain. So they are all put together in a single name, that is the nociplastic pain, and it is one of the most difficult sort of pain to treat. And remember, when the pain goes in a very chronic phase, it actually from nociceptive is either goes to the neuropathic character, some neuropathic character, or sometimes it's called a mixed character also. Mixed character pain also occurs. So where some sort of nociceptive and some sort of neuropathic component will be there. So we have to ask the character of the pain. Okay. As it's a one of the process where I'm going a little bit deeper, that's why I'm asking, because today I have time as well. Next is the duration of pain. How long is your pain? So if the pain is chronic, you can think of the chronic causes of the pain. Okay. How is the progress? Okay. Sometimes the patient can say, I am having recurrent pain in down my back, which comes in once in a 6 month or once in every year, that is coming for last 2 3 years. So you can think of a condition that could be causing recurrent back pain. For example, it could be a possible case of spondyloarthropathy. And definitely other factors like age, sex, that also helps here. Okay. Young male patient with such findings, then we can get more sure that it could be a cause that is causing by a spondyloarthropathy. Okay, that is the importance. Then location of the pain, exactly whether first of all it is a precise location or non-precise location. I have told the pain originating from a degeneration of the disc, usually a poorly localized pain. Pain originating from a complex regional pain syndrome, either reflexive sympathetic dystrophy or causalgia, we are poorly localizing pain. Okay. But pain originating from a facet source, it's a sharply localizing pain. Pain originating from a myofascial trigger point, it's a sharply localizing pain. Pain originating from a nerve root and causing radiculopathy, that is also a very sharply localizing pain. That is also very, very important. Next, come to the radiation. I've already discussed a lot about the radiculopathy and radicular pain, so you can understand it could be possible cause of radiation. But remember, it is not the only radiculopathy that radiates, because the greater occipital neuralgia, and there is also here is the cervical plexus from where 2 nerves are coming, one coming anterior to the ear, that is great auricular, and one nerve coming posterior to the ear, that is the lesser occipital nerve. That could be affected as well, and that can cause a neuralgia as well, and that will be radiating pain towards that nerve. So this is the red pain radiation. Then what are the aggravating factors and relieving factors? If it is a joint pain, more likely the pain will be increasing after a rest. Okay, so spondyloarthropathy patients or a rheumatoid arthritis patient after taking rest usually says that my pain is increased. As well as there is one differentiating factor here. In degenerative arthritis also after rest the pain increases, because degenerative arthritis pain do not occur at the rest. When the patient starts moving, the pain starts appearing, but there is a big difference that when the degenerative arthropathy patient start moving, initial 5 to 10 minutes pain only be there. Then their pain will be relieved. Whereas when an inflammatory disorder or pain with inflammatory cause it is there, it will remain there for half to 1 hour. Okay. Usually, pain lasting more than 1 hour, there is a more chance of a inflammatory pain, which increases on rest. Okay, so these are few clues by which we can think of which type of pain is actually happening. Then associated neurodeficit, which area is the neurodeficit, and how it is involved. And remember, while evaluating the patient, okay, now we are mostly concerned with the causes of the neck pain. So I'm not going. But sometimes it could happen. Patient with a Hansen's disease is coming to you and showing the anesthesia here. See, in your mind, it should be play that there could be Hansen's disease as well. Okay, you check the nerves then. So you have to be a detective, a simple word, to find out which is causing the pain. And definitely age of onset that also help know from which area or which structure the pain is originating. Then we have to take the other histories as well. Among the other histories, we have to ask for the occupational history. We have to ask for the family history. We have to ask for the personal history. Previous medical history, very, very important. Sometimes a lot of clues come out from the previous medical history. Do not ignore that. Okay. Do not depend on that. So it can cause either a positive influence or a negative influence. Sometimes it might happen. So I've seen the previous reports and the same thing will come to your mind. You will be stop thinking of the other possibilities. So don't do that. You check them. That is also a very important source of information. Okay. And most of the important thing is the psychological assessment. Remember, psychological assessment is also a very important part because in chronic pain, most of the age patients do have some psychological components. It could be in the form of depression. It could be in the form of anxiety disorder. Usually it is there. And most of the psychological problems usually goes off once you can control the nociceptive part or central component of the pain is. So you do not ignore that. Now in general examination, check for the gait, check for the body habitus, check for the hair functions. These are very, very simple things. Actually, when the patient is coming to you, you should check this. The patient coming to your OPD, and at the time you look at this very, very important things. If you find there is a problem in the gait, you can ask the patient to walk and to find out which type of gait the patient is having. Now coming to the neck examination. The neck examination, as I told, it has the following components. First, you need to inspect for any skin changes. Okay. So what could skin changes could be possible? There could be redness, there could be pigmentation, there could be presence of swelling. So you have to check those in a patient. Okay. Next, you have to go for the palpation, then range of movement analysis, then neurological examination, and finally specialties. So in inspection, you should check the skin condition, head, neck posture, shoulder symmetry, presence of muscle wasting. This is very, very important because sometimes in a patient, you are finding that thinner eminence is one. Okay, the fullness of the thinner eminence is not there. So you can think of the patient might have any component that is actually compressing over a median nerve, either its root or in a path. It could be a case of carpal tunnel syndrome. It could be a case of medial nerve entrapment in any one other form in upper part as well. So you have to find out these things on the inspection. Now coming to the palpation. Remember, there are few important points in the palpation part that you need to know that first of all, that is the rough location of the styloid. It is in between the first, this is the angle of mandible, and this is the posteriorly, there is the mastoid process. Exactly in the center is approximate location of your styloid process. Sometimes there could be a long styloid. Now, this long styloid sometimes cause the irritation over the nerve. And over which nerve it commonly irritates? Can anyone tell?
Glossopharyngeal.
Glossopharyngeal nerve. So there could be pain in this area. And this is known as the glossopharyngeal neuralgia, sometimes found in some patients. And so this is the rough location of the styloid. And slightly anterior to the styloid remains one important parameter, though it is very difficult to palpate. It is the transverse process of the C1 remains at that point. So at the level of the thyroid bone, usually, so three landmarks anteriorly is easily palpable. One is definitely the thyroid, most easily palpable. And below the thyroid, we have the cricoid that is also very easily palpable. And above the thyroid, we have the hyoid that is also easily palpable. So at the level of the hyoid, we have the C2, C3, C4 facet joint. At the level of the thyroid cartilage, we have the C4-5 vertebral body and the facet joint. At the level of the cricoid, we have the C6 transverse process, which is tubercle, which is known as the Shishagnax tubercle. And that is one of the very important landmarks for our stellate ganglion block. Okay, those stellate ganglion remains at the level of the C7. For the safety, we block at the level of the C6. Next, we can go check the head of the fasting and first costochondral joint. Okay? So that could be actually a source of the pain which can go to the neck. So we have to, these bony structures, you should palpate from the anteriorly, and this knowing these structures is also very, very important to find out where the pain is. Now coming to the soft tissue palpation at the anterior side. So you have to check for the thyroid, for the swelling or the nodule. Then we have to check for the cervical lymph nodes, whether there is enlargement present or not. It could be possible infection, it could be possible metastasis. Okay, the lymph node could be palpable. Then we have assess the muscles for the presence of any trigger or tender point. Okay. So these are the soft tissue landmarks in the anterior side that we need to check. Now goes to the posterior side palpation. In the posteriorly, we have to check the occiput, the external occipital protuberances, superior nuchal line, and the mastoid processes. Remember, over the superior nuchal line, usually 3 centimeters from the midline over the superior medial mid-nuchal line is the rough location of the greater occipital nerve. So if the pain you palpate there, the pain is coming over the posterior part and sometimes comes up to the frontal bone as well. Okay, so it can radiate up to this area. If there is pain and pain is reproduced, there could be a possible greater occipital neuralgia. Similarly, if we go to the lateral side and along the line joining the occiput and the mastoid process at the junction of the medial 2/3 and lateral 1/3, that's the rough location of the lesser occipital nerve. Actually, when we see under the ultrasound, we can see the greater and lesser occipital nerve as well. This way, it's a bit difficult to see, but you can, if you track very with time and very good machine, you'll be able to see the lesser occipital nerve as well. So, if the lesser occipital neuralgia is there, you can put a local anesthetic and find out the pain is gone or not. Diagnostic block helps a lot. Now, facet joints, as I told, it is present 2 to 3 centimeters from the midline. And remember, facet pain is one of the commonest type of pain, probably after the myofascial or the muscle origin pains. So that could be another possible cause of pain. So check the facets. Okay. Then palpation of the lateral atlantoaxial joint, which is performed by rotating the patient's head one side, and you should check in the posterior and ipsilateral area. Okay. That is the C1, C2 joint, but it is usually commonly not involved, I should say. It's not that it could not be involved. It is not commonly involved joints. C3, C4, and C5. In fact, most commonly these three are involved in the cervical area, especially the C5, C4-5, C5-6, and C6-7. These are the three areas involved mostly. In the lumbar area, L4-5 and L5S1 is the most commonly involved. Here, these three are most commonly involved. C3-4, C3, C4, and C5. Okay, these vertebrae are difficult to palpate because it is a little deep, and because of the cervical lordosis, these vertebrae are a little bit anterior, so it is difficult to palpate. And C7 we can easily identify with large spinous process, easy to palpate. Especially under fluoroscopy, it is very easy to locate the levels. It is very easy to do the procedure. But under ultrasound, these are the few landmarks like C7, C2 that can be easily identified. The rest of the vertebral level you have to go by checking the spaces. Okay. Now coming to the palpation in the posterior side, mainly the soft tissue palpation. In the soft tissue palpation of the posterior side, we have to check the suboccipital triangle, suboccipital muscles, and the trapezius muscle for assessment of any trigger point or tender point. Then we have to check the paraspinal muscles for the stiffness, any trigger point, tender point. You have to check for the intraspinal space at the center. Find out whether the pain is present because of this intraspinous tendinitis or not. Then we have to check the posterior group of the lymph nodes as well for the malignant or inflammatory involvement. Okay, These are the things that we need to note in a case of the cervical spine. Now coming to the range of motion can be affected either by a bony structure like osteophyte, or it could be affected by pain as well. Usual normal flexion is 40 to 60 degree. Extension is 50 to 70 degree. Mainly flexion is restricted by the chin, which is stacking over the chest. In lateral flexion, it is around 20 to 45 degree. These are the lateral flexions. And rotation is around 60 to 80 degree in either side. So these are the usual normal range of movement. If it is affected or not, we have to check this thing. Now coming to the neurological examination, we have to check cranial nerve examination. So these are things we are not going to repeat, but definitely so just review your initial books of the clinical methods. Then you have to go for the check for the cervical nerve testing, mainly the functions of the sensory, motor, and reflexes. Okay. These are the sensory dermatomal distribution that I've already told you. So you have to find out if there is a sensory loss present. If it is along the root or along any form structure along form nerve, we have to find out by which we can get an idea this nerve could be possibly affected. Now in the motor component, if C2 is affected, mainly the neck flexors are affected. If C3 is affected, mainly the lateral flexors of the neck are affected. C4, mainly the shoulder elevation is affected. C5, there could be involvement of the deltoid muscle and the abduction of the arm and the shoulder joint could be affected. C6, the biceps, the flexors of the arm and the elbow joint could be affected. C7, triceps, the extensor of the upper arm is affected. C8, small muscles of the hand is affected. C1, the finger abduction, meaning to the ulnar nerve that could be affected. So these are the usual point to note whether they are present or not. Coming to the reflexes, we commonly check for reflexes in two areas. One is the elbow flexion, which is caused by the biceps reflex. So we put a finger over the biceps tendon, maybe the long tendon of the biceps, which is actually attaching to the radial tuberosity. Like this, you have to put the hand, and usually putting a thumb, you should strike. The hand should be free and you should strike with it, and it is mediated by the musculocutaneous nerve, and the response is the elbow flexion. Similarly, as to put the hand like this, and you can go for the lower part of the triceps, and that is actually spinal root 6, 7, and 8, and the nerve is the radial nerve, and it would cause elbow extension. So the reflexes we have checked. So as I told, the sensory, motor, reflex, we need to check. Next, we have to go for the special test. Remember, they are always special because they have specific names, and you have to know these tests, and you have to commonly perform these tests as well. Other tests are also very important, but special test you should not forget. So, but before going to the special test, if there is any question from any one of you.
Hi, can I ask, when you have a cervical radicular pain or a specific
Yes.
cervical nerve root, like if it was C5, would you
Yes.
have involvement on your clinical exam of all the nerve roots above it, or would you have clinical difficulty looking if there's inflammation affecting the nerve root above and below? Is that a possibility?
Thing is, if you are getting a pain along the cervical nerve root C5, so there could be possibly that if it's a radicular pain, remember, everything should be normal. As I told you in the difference between radiculopathy and radicular pain. But in this case, my primary thing is to look for the C5, but then I will check the other nerves as well. Okay, so it all depends. Ideally, we should check all, but in practical part, like in India, there's a lot of OPD and patients, the number is huge. So sometimes we are not able to check all the nerves. Ideally, it is to be done. The check should be proper. Okay.
Thank you.
Okay. Let's move to the special test. So just 1 second. I have to start the sound transmission as well, because these videos have the sounds, share sound. Okay. So what is shoulder abduction test? So I'm just first asking you, saying you the concept, then I am showing the video. So in shoulder abduction test, it has been found if the shoulder is like this, okay? Usually when the shoulder is hanging by the sides, usually there is more stitching over the cervical nerves. Okay? So usually the patient with acute radiculopathy usually says, when I'm having pain, in this posture I'm having more pain. Ask the same patient to put and hold the hand like this. Okay, so just after 1-2 seconds time, the patient will get a little relief of the pain, and this is known as the shoulder abduction sign. And this is one of the feature of the cervical radiculopathy, especially in the early stage. Okay, in later stage sometimes both have the pain, but in the early stage usually shoulder abduction test usually gives some relief. Okay, next test is the cervical distraction test. So shoulder abduction has nothing to do. Doctor cannot not does anything. He just asks the patient to put the hand like this. But in shoulder distraction test, there could be two possible ways. One, the patient is lying over the bed and the head is put axial traction over the head and chin, or the patient is sitting and I am putting axial traction. So these two tests are mainly to relieve the
Now I want to perform the cervical distraction test. So this is also a test for the cervical radiculopathy. If this test relieves the patient's pain, then it is diagnosed that patient has a foraminal compression or radicular pain. So how the test is done? The patient's head is neutral here, and then I will put one hand under the chin and other hand under the occiput, and I will give a upward pressure or upward, I will pull upward so that there is a distraction at the cervical spine level, cervical foraminal level also. So if the pain is relieved, it will be cervical distraction test positive, which is giving us a diagnosis of cervical radiculopathy or foraminal compression.
Okay. So that was all about the cervical distraction test. Similarly, there are two tests. Two tests I have shown you, that is actual relief of pain, and there are two tests which actually can increase the pain. So one of those is the Sparling's test. So let us see how the Sparling test is performed.
Now I want to perform the Sparling's test on this patient. So okay, first I will go for the simple extension of the head, and then there is lateral bending on the affected side, and with this position maintained, I will give a compression on his head. So if there is a pain which is produced on the right side, then we know that there is a right-sided radiculopathy or there is a foraminal compression on the nerve root. And the same thing again, I will go in the neutral position, I will do a extension, and then I will bend on the left side, and then again I can put a compression, axial compression on his head. So if this position on the compression, on giving this compression pressure, if there is a production of pain on the left side, then there is a foraminal nerve root compression on the left side.
So that is what is the Sparling's test. This is basically to increase the pain. Okay. Next test is the Jackson's compression test. So it is also a similar type of test that is also increasing the pain. So let's see.
Now I want to perform the Jackson's axial compression test. So for this test, what I will do is first I will tell him to rotate the head on the right side. So he is rotating the head on right side. Then I will put a compression on his head for few seconds, and then I will ask him that if there is a reproduction of radicular pain on the right side. Then I will tell him to rotate the head on the left side. Then again I will put a compression on his head axially for few seconds, and I will tell him that whether there is a production of radicular pain on his left side. If there is any radicular pain produced, then I will assume that Jackson axial compression test is positive.
Okay.
Now I want to perform the Jackson's.
So I think this type of things you have already know. Now, there are two tests. They are mainly for the severe cases. One is the Valsalva maneuver. If there is a large radiculopathy, Valsalva maneuver ideally should be performed in putting the intrathoracic pressure against the closed glottis, but it is sometimes very difficult to make to understand to the patient. So another common technique sometimes employed is patient is blowing from the mouth and ask the patient to put the thumb there to stop. So it is also the same type of maneuver. It will increase the intrathoracic pressure as well as the interspinal pressure. So if it increases the pain of the neck pain, it could be a possibly there could be a large mass or a large disc might be present. Because of the increase in the interspinal tension, the pain is increasing. Similarly, there is another term that test is there, that is known as lamitive sign, where there is the production of the paresthesia or dysesthesia in arms or legs upon the flexion of the cervical spine, which again can be caused by a large disc herniation, a bony compression, or a neoplasm or a syringomyelia, which usually can cause pain. Okay, so that is the lamitive sign. So these are the special tests, though. Thus, these are very serious conditions. When we are getting the Valsalva positive or lamitive sign positive, usually the patient is very serious. So in the final, I think minutes, I should describe this chart. So it's a very complex chart, but if we see carefully, we can identify which flight is going to which area. So first, when we are evaluating in the beginning, we should rule out the red flags. That's the basics. Now check whether the pain is only in the neck or neck pain along with the hand pain or neck pain with headache. So when only neck pain, you have to check whether there is the axial neck pain or it's a paramedian neck pain. Okay. Now, if it is a midline neck pain with tenderness over the spine, whether pain poorly localized, it could be possibly a pain originating from the disc, and it's discogenic pain, or sometimes it is called internal disc disruption. It could be mainly only neck pain, poorly localizing, as it is mediated mostly by the sympathetic nerves, and yeah, usually there should not be any radicular component. Okay, and when pain is well localized and increase on neck extension, lateral flexion, or rotation, there could be possibility of the bilateral facet arthropathy. Remember, we usually say when the facet pain is there, it is one-sided affected, but when the bilateral joints are involved, it could be a sharply localizing pain in both the sides, and extension will increase the pain. Now, axial neck pain with midline tenderness between the spines and increased on forward flexion, it could be a sprain of the intraspinous ligament, that is in between two spines. So it's a paramedian neck pain with pain well localized, increases on neck extension, lateral flexion and rotation. It could be a unilateral facet arthropathy. Then paramedian neck pain is usually more paramedian than the facet pain, and it is like a trigger point over a muscle. It could be a possible myofascial pain. Now, neck pain, along with hand pain, along with global radiation, global allodynia, poorly localization, dermatomal changes, like when we'll be talking about the CRPS, we'll be talking about those signs and changes of the CRPS. It could be a possibility of CRPS. So there will be change in color, temperature, hairs falling. There could be another possibility. So it's a rare condition, but sometimes it could happen following the injury to the hand, and sometimes it could happen even a trivial injury, sometimes forgotten, like intramuscular injection, that can also cause a CRPS. Now, a neck pain with a patchy radiation, which is mainly dermatomal radiation with tingling, numbness, shooting pain, sometimes with the sensory motor loss, and Sparlungs or Valsalva positive, it could be a radiculopathy. Then there could be a dermatomal distribution with pinprick sign, hyperalgesia, allodynia, and with the post-herpetic sign. There could be possible post-herpetic neuralgia. Then a dermatomal distribution with numbness, hypothesia, sensation, with diabetes history, there could be diabetic principal neuropathic pain. Then again, a catchy non-dermatomal distribution along the nerve distribution. There could be a nerve entrapment or brachial plexus or plexopathy. It could be possibility. And because it happens after the formation of the nerve, so typical dermatomal distribution will not be there. And if there is a pain not along the nerve distribution, like pain in the shoulder joint or muscular trigger joint or facet tendinous, it could be a referred pain from the facet joint. But remember, referred pain from the facet joint rarely goes below the shoulder, and it usually not goes before the elbow. Okay, and neck pain with headache. Let's see in the next chart. So neck pain with headache or cervicogenic headache, limited neck movement, dull aching pain, trigger point present, tenderness over the muscles. So it could be a myofascial pain. Okay? Then sharp shooting pain and tenderness along with the distribution of the greater occipital nerve or lesser occipital nerve. It could be a greater or lesser occipital neuralgia. Pain which is well localized, then increase on the neck extension, lateral flexion, or rotation. It could be a facet joint pain radiating towards the head. Then there is a predominant headache, okay, and fixed duration attacks associated with the prodromal or aura symptoms. It could be possibly migraine. So it is a very rough chart. Remember, a lot of things are there. We tried to put most of the important things that we should and common things that we should try to find out in a case of neck pain. So I think that my lecture part is over. Now it's a discussion part. So do you have a question?
Sir,
Yes.
sir, in cervical distraction test, will the pain from radicular pain or radiculopathy both will be relieved?
Yes. In fact, see, radicular pain usually occurs either in the early stage or when there is only nerve irritation. Okay. And radiculopathy usually occurs after this. Okay. But yes, both component could reduce. But how much it will reduce depending on the condition. Definitely. It could not be same. I have told you, no, these both terms sometimes are very overlapping terms.
Okay, sir.
So any more questions? Okay. No questions. So I hope we have all reading very seriously because that is our motto or aim. Because even if you see the whole class, but if you do not recapitulate the things, you do not see the recordings afterwards, it is not, it will forget because lot of things we are talking in 1.5 hours or 2 hours, and you have to remember each and everything. So the first thing, you see the recordings at least 2 times. It is minimal. Read the study material and then appear in the test. If you do these 3 things now, then I think it will not be a problem. Your learning will be very smooth. If you do not go with the class, if you think I will collect it and I will read it later, I will see it later, then the later day will never come. Okay. So may I end today? Okay. Good night, everybody.
Thank you, sir. Good night.
Thank you, sir. Good night, sir.
Madam,
Thank you.
start off
Thank you, sir.
meeting.